Bismillahirrahmanirrahim. I formally welcome all of you on behalf of Pakistan Pharmaceutical Manufacturers Association. The real show begins now. I have the honor and privilege of introducing our worthy speaker, Professor Dr. Zaheer-ud-Din Babar. Very briefly, and I'll take few minutes for his introduction so all the participants know his expertise and then they can benefit from his presentation and from his Q&A session. Dr. Zaheer-ud-Din Babar Sahab, he is a professor in medicine and health, University of Huddersfield, UK. He is the director, Pharmaceutical Policy and Practice Center. He is an author of Pharmaceutical Prices in the 21st Century. He is an editor-in-chief, Encyclopedia of Pharmacy Practice and Clinical Pharmacy. He is also editor-in-chief, BMC Journal of Pharmaceutical Policy and Practice. Dr. Zaheer-ud-Din Babar is a professor in medicines and healthcare and the director, Center of Pharmaceutical Policy and Practice Research at the University of Huddersfield, United Kingdom. He is globally known for his work in the pharmaceutical policy and practice, including quality use of medicines, clinical pharmacy practice, access to medicines, and issues related to pharmacoeconomics. He has published in high-impact journals such as PLOS Medicine and The Lancet, and has acted as a consultant for WHO, World Health Organization, Royal Pharmaceutical Society, Health Action International, International Union Against Tuberculosis and Lung Disease, World Bank, European Union, International Pharmaceutical Federation, which is FIP, and for the Pharmaceutical Management Agency of New Zealand. His edited work includes economic evaluation of pharmacy services, pharmaceutical prices in the 21st century, pharmaceutical policies in the countries with developing healthcare system, global pharmaceutical policy, access to high-cost medicines, pharmacy practice research methods, pharmacy practice research case studies, and Encyclopedia of Pharmacy Practice and Clinical Pharmacy, published by Elsevier and Iris Springer. The work is used in curriculum design, policy development, and for referral all around the globe. Professor Dr. Zaheer-ud-Din Babar is on a 9-week tour of Pakistan, Malaysia, and one more country just mentioned to me. A 9-week tour. He's delivering lectures and presenting his papers. From today to I think tomorrow or day after tomorrow, he's going to LUMS, where he's going to talk about the pricing policy. So his expertise is pricing and many others. He has also worked in AKUH in Karachi, a very brief stint. So he has a good knowledge of Pakistan as well as the global economic situation and the global pricing and the global pharmacy practice. So I'm sure we all, as worthy participants, can take advantage of his experience and knowledge to learn how we can create a balanced pricing policy in this country, which we have been fighting for a very, very long time. I see a lot of worthy participants from across the industry, across the companies, from the regulatory side as well as the other fields of production and technical side. I'm sure we all can benefit and go back to our offices and actually take up the challenge how we can use our influence to have a better pricing policy for the worthy citizens of this country. So I request, without any due delay, Professor Zaheer-ud-Din Babar to take the stage. He will have almost 2 hours, probably more, depending on your the knowledge-seeking ability, and I'm sure we all can learn from his expertise. Dr. Zaheer-ud-Din Babar sir, please. Thank you. A big round of applause, please.
Bismillahirrahmanirrahim. Very good morning to all of you. I would like to say thank you to Harun Qasim Saab for very nice introduction. Also thank you to Kaisa Wahid Saab, my colleague Dr. Hamid Merchant, Adnan Hirani Saab, another colleague of mine, Sayyid Shamim Raza, who is sitting here as well. Thank you for inviting me to Karachi and to speak about this very important topic on medicines pricing policy. So what I'm going to talk about today is actually coming from my work and experiences, because I have worked in Malaysia. I'm a pharmacist. I've worked in Malaysia as an academic, and I've also worked in New Zealand at the University of Auckland as the head of pharmacy practice. And now I'm based in the UK. And in the last 15 to 20 years, we have actually done original research work on pricing in 30 over countries. So what I'm presenting today is coming from my own original research work, whether it's in Malaysia, Thailand, Far East, Australia, New Zealand, European Union, England, Pakistan, Bangladesh, Sri Lanka, and Nepal. So many of these countries have actually worked on the pricing policy. And I was very interested in the pricing policy because the previous Minister of Health appointed me as the advisor to draft Pakistan's medicines pricing policy last year. On his advice, I was officially appointed, and I actually worked and presented the policy. So some of the work which I'm presenting today was actually sort of the work which I did and presented to them. Unfortunately, the government has a change, and then it was not, implemented in this context. But in this session today, I'm going to give a sort of an introduction that pricing is not something which you just sit down and do 2 + 2. Pricing is also not purely management. Medicine pricing is a public health issue. It's a public health and public policy issue rather than more sort of a management issue. So first I'm going to give a global snapshot that why pricing is important, in what context pricing is important, and then I will sort of zoom in Pakistan and not only talk about the situation in Pakistan, but also present that what kind of solution we could have, what kind of pricing policies we could have, because the pricing policy is not a single policy, it's a mixture of different sort of policies. So in any country where there is a pricing policy, it's not a single policy. It's a kind of a mixture of different sort of policies which are sort of mixed and matched, and then a pricing policy is determined. As my colleague Kaisa Wahid Saab has rightly pointed out, it's a bit of a dry topic. It's not an easy topic to comprehend, but I will try to make it as interesting as I could on this issue. But first, I would like to set the scene for the pricing. So I'm going to provide a global overview of global pharmaceutical pricing, and then provide a detailed analysis of Pakistan's medicines pricing policy. As you know, that the global medicine market is expected to grow at 3 to 6% through 2025, reaching about 1.6 trillion in total market size. It's actually expanding, and it's growing at a very, very fast pace. These are the countries at the top. You would see the global per capita medicine spending from 2007 to 2021. You can see United States at the top, then followed by Canada, Japan, Europe, Australia, South Korea. Pakistan, India, and Bangladesh are perhaps at very lower sort of spectrum in terms of value of these products. So most money which is being generated by pharmaceutical industry is in United States and European Union. And the reason you have why it's more so in United States, because United States practices a free market economy. So there is no pricing policy in United States. So pharmaceutical industry can actually sort of regulate their own pricing. So you don't have to set the prices. The prices are not set by the government, but actually the prices are set by the pharmaceutical industry. And that's why you would see that United States is at the top. So that's the single most important reason. It's so important that actually it drives sort of, it is being said that it drives innovation, it drives the market and this. There are major challenges with regards to access to medicine and pricing, because when I talk about access to medicine situation, pricing is one of the single most important component in access to medicine. It's the single most important component because in access to medicine, there could be other components as well. But pricing is at the top. Half of medicine spending is in the US and European Union, followed by Europe, Japan, and emerging economies. You have specialty medicine growth such as cancer, diabetes, autoimmune disorders. Drug expenditures are rising faster than other healthcare costs. So drug expenditures are actually different than pricing because the pricing multiplied by the consumption of drugs would actually translate into drug expenditures. So these are some of the contributing factors. We have new high-priced medicines which are coming to the market. There is an aging population, not only in high-income countries, United States, Australia, New Zealand, European Union, but also this trend, we see largely this trend in low and middle income countries as well. So not only in high income countries, but we also see in low and middle income countries that there is an aging population. There is increased demand for specialty treatment and products by the patient. And the reason why I'm saying so, because you have now internet, you have a digital age. So people are more concerned. They can actually go through internet and they can look at the products and they can actually ask for the products. As I said, pricing is a public health issue. It's less of a management issue and more of a public health and public policy issue. So that's why access to essential medicine is in the United Nations Sustainable Development Goals. So access to safe, effective, quality, and affordable essential medicines for all, it's goal 3.8 of UN Sustainable Development Goals. So as people talk about essential commodity, access to essential commodities for sugar, for other essential things in life, so the same way people talk about essential medicines as well. It's also considered a fundamental human right, but then 400 million people lack health care, including access to medicine, and 300 million people live in middle-income countries. Previously, access to medicine was an issue which was only considered for poor countries, that they can't afford medicines. But increasingly, we see that some of the European countries and rich countries, they're also facing challenges. And why they're facing challenges? Because of increased demand for specialty treatment. Many European countries, cancer medicines, they constitute about 25 to 30% or 50% of health budget. So it's becoming a major sort of an issue, not only for poor countries, but also for high-income countries as well. The Lancet Commission actually estimated that you need about $13 to $25 per capita to finance a basic package of around 200 essential medicines in all low and middle income countries. But interestingly, many low and middle income countries, they spend about less than $13 per capita on pharmaceuticals. So this is really, really very low, that the focus on pharmaceuticals is really low. So the major issue we have in terms of access debate is actually the less public money which is being spent on pharmaceuticals. And I think there are huge potential to work in this direction and in this area. I'm going to give you an example. Pharmaceutical industry is sitting here, the effectiveness of medicine. And this is a very interesting and classical example that how medicines could actually improve health outcomes. So for example, the cardiovascular disease fell by 30% in rich countries between 1990 to 2017, 30%. And this is all because of use of cardiovascular medicines. And this only declined 9% in poor countries. And why it fell 9%? Because the people in poor countries, they don't have access to cardiovascular medicines. So where you have excess is actually sort of fell 30%. So this sort of informed you the powerful and strong narrative of role of pharmaceuticals and quote unquote role of pharmaceutical industry as well to promote health outcomes and patient health outcomes as well. But what are the factors which are impacting on access and equity to medicine? So there are no government control on drug prices. In many countries around the world, Pakistan has an absolutely control. Pakistan, Bangladesh, and India, they control medicine prices at the community pharmacy level with the maximum retail markups. But not all countries in the world have similar sort of control. So for example, in Malaysia, United States, absolutely they have no government control whatsoever on drug prices, and the pharmaceutical industry actually set their own prices. So this could lead to having an impact on access to medicine, the excessive use of innovative brand. I think we have all local pharmaceutical industry which is sitting here, but in some countries you have innovative brand. So innovative brand, I'm sure you would know that the first time a company manufacture a brand, it's called an innovative brand. And then afterward, everything which is being produced, it's called generics. So generics could be branded generics or generics. So my understanding in Pakistan, mostly branded generics are produced or generics are produced. So in some countries, there are excessive use of innovative brands. There is no government control on drug prices. Patents, this is another sort of a major sort of an issue, especially in United States, where some of the patents been given 20 plus years, where you can actually change the name of the product, you could change a little bit indication, and you could have another 10 years added to the patent life. In some countries, United States has signed free trade agreements. So if the United States sign a free trade agreement with a country, then it means that the US laws would apply, and then they would have the patent extensions as well. So for example, if the US is giving a patent extension for 30 years for a medicine, then the country would have a patent extension. And we have seen many of the countries around the world where US has signed free trade deals. And that's why these free trade deals are not really good, because they would apply in all sorts of settings. It could be good for big pharma because they would reap profits, but it's not going to be good for the public health and for the consumers and for patients. We also see the development of specialty drugs, cancer, orphan medicine in the recent years. So these are some of the challenges we see impacting on access and equity of medicines. This is a very interesting slide, and it actually gives you an idea. Access to cancer medicines in 34 countries for metastatic melanoma. There is a greater discrepancy which exists. Treatment globally, access depend on economic as well as healthcare system performance, and price negotiation and managed agreements are needed. And in many of these countries, even European countries, and we have done a lot of work in Europe and Australia and New Zealand, and we have seen that pharmaceutical industry actually apply for the newer cancer medicines, they do a lot of managed entry agreement. So they actually work with patient organizations, with hospitals to promote access to newer cancer medicines. But still we see that there is a sort of a discrepancy which exists. So it's not uniform. So this is really sort of a worrying situation. We also see that the prices of older drugs which are being increased. WHO essential generic medicine sold in UK and South Africa priced more than 100 times at the estimated cost of production. I'm sure that all of you are very well aware of this case of Daraprem, pyrimethamine, which was an old drug in 70s, but Turing Pharmaceuticals actually increased the price of tablet from $13 to $750 where they have over 5,000 increase in price. For some of the older drugs, I'm not talking about all older medicines, but some of the older drugs, we see the price increase for these medicines as well. So we see that we have newer innovative cancer drugs which are going up, but we also see that the older medicines as well. US FDA approval of new oncology drugs have increased over 200%. Orphan drugs have increased over 175%. In 2015, 65% of new active substances approved by FDA, European Medicine Agency, and Health Canada, they were sort of specialty drugs. So because in specialty drugs, we see a lot of profitability, hence we see that approvals have gone up as well. This is the prices of newer cancer treatments and multiple sclerosis. In mid-90s, this was around 8,000 to around 11,000 per year, and this has gone up to $60,000 per year in 2015. Of course, there's inflation, there's other cost as well, but just to give you an idea, and the similar sort of things where we see the cancer treatments gone up over $10,000, and this is per person. So I'm sure that people who do a lot of global work here, they would know the prices of drugs and the cost of treatment globally. How is it like? And in the United States, it has been argued that excessive pharmaceutical prices and revenues are fair because development costs are higher. But one of the challenges we have is that big pharma do not disclose their research and development costs. Many orphan drugs are being approved based on smaller trials and lower development costs. So there are not bigger trials which are needed for orphan drugs. So maybe you're not spending the similar amount of money to develop a new orphan drugs as you would spend for the other drugs as well. So these were some of the issues which I've talked about. In summary, what we have a world where there were problems previously only for low and middle income countries, but we also see that there are now problems for high income countries as well. We have aging population, and we have in some countries there are strict price control. In some countries, absolutely there is no price control. And from experience, I'm going to show you some examples that in countries where there are strict price control, the prices are on the lower side. When there is no strict price control, the prices would always go up. There are also some other issues which are impacting on access and pricing. And I'm going to touch base some of this very briefly, that what could be the other sort of issues. Some other issues could be voluntary licenses to promote access, price secrecy and discrimination, reporting of pharmaceutical expenditures and access by pharmaceutical industry, affordability and uptake of medicines, and patient-centered comprehensive primary care services. Because interestingly, in some African countries and some Asian countries, it was also observed, I've not quoted the examples here, but in patient-centered comprehensive services, that even if you sell medicines at a very low price, even $1 or even less than that, patient uptake was very challenging. So when the WHO and other international agencies were working to promote access to medicines and they were giving it a very, very low price, the patients were actually not taking medicine. So there is something else as well in this whole debate of pricing. So there is something else, and that's why we think that at community level, pharmacists, doctors, and they have to work together for the patient, whether we call it pharmaceutical care, nursing care, or medical care. This was the voluntary licenses for hepatitis C medicines in 34 countries. Since 2014, non-exclusive licenses have been issued by two of these companies for key drugs. and voluntary licenses were associated with increase in annual number of people as accessing hepatitis treatment. So the evidence support that expansion of licensing strategies to include more countries and more treatments. My understanding is also that in Pakistan there are few companies who are working with overseas companies, and they have been given licenses as well to promote access. Confidential price discounts allows manufacturers to charge different payers at different prices. Although they reduce final prices, the widespread use of confidential discount is still a concern for health system because the prices which are being listed on the different regulatory authorities or bodies, what you see are not real prices because they have confidential discounts and rebates which are being given. So it's something similar to what we have seen in COVID-19 vaccine prices, though there were some prices which were being disclosed by the government, but they were not real prices. And in a bit, in 5 minutes time, I will show you some slides from some other countries where actually there were no the prices which were listed were not the real prices. So this makes it a challenge for countries like Pakistan, because Pakistan would like to benchmark their prices with other countries. But the problem we have is that what are those countries and where you're getting those prices from, basically. And even if you're getting the list prices, they're not real prices. So in whole pricing debate, if you would like to set your own prices, where would you be getting your benchmark? And even if you get the benchmark, those benchmarks would not be authentic because they would have discounts and rebates which would be built in this. So this is a sort of a model which I developed. I didn't copy it from somewhere. So I presented in a conference last year. So there's a model where you have these different portions and components of pricing. So you would have in the access to medicine debate, but I still consider this section is one of the biggest which impact on promoting access. There could have others such as generics, availability, procurement, transparency, voluntary licensing, but I still consider this one factor is a very, very important factor to promote. And Pakistan really does very well in this aspect, which is generic medicine. So, and I think your pharmaceutical industry plays a very important role through generic medicines, whether they are branded generics or they are real generics with the non-international, non-proprietary name. So we have talked about some of these problems. So what are the solutions? And different countries have come up a different solution, because I'm just trying to give you an idea that pricing is something which is not only Pakistan's problem. It's a global problem for every country. And every country would actually deal with it with their own sort of, parameters and their own sort of things. I know you would like to listen about Pakistan, and I'm coming to this at an end, but I thought it was important to set the scene so that you would know the real perspective that where all this thing is coming from, actually. So what are the solutions? So this was an article which was published in BMJ in 2020, and my colleague Suri Moon, she works in Geneva in Switzerland. So she wrote the concept of fair pricing for medicine. So basically she argued the mechanism to dealing drug development costs from final pricing are required, and she called it building a model for the fair pricing of medicine. So fair pricing means that we would like to give fair prices to the pharmaceutical industry, but at the same time, we'd also like to protect consumer. So pricing doesn't mean that we want to penalize pharmaceutical industry. So it doesn't have to be that way. So the pricing means that you actually have a sort of a balanced approach in which you have profitability for pharmaceutical industry, but at the same time you are safeguarding the interests of consumer as well. And as you can see from all these slides, pricing is a science in which you have pharmacists, you have doctors, you have health economists, you have political scientists, everybody is sitting together and actually making a sort of a pricing policy. So it's not purely a management issue. It's more towards a public health issue. Most countries in the world, they control medicine prices either through direct control, controlling prices at the government level, what we see in Pakistan, that you control prices at the community pharmacy level with the maximum retail price, or you control through indirect control. And this is very interesting for those audience who have not seen the outside Pakistan system. And this is through, is called through pharmacoeconomics. I don't know how many of you have heard this term before, and we're going to touch base on it. So it's basically value-based pricing. And this is mostly done in those countries where you have what we call universal health coverage. So for example, United Kingdom, Australia, New Zealand, Canada, and many other European countries where you have universal health coverage. Universal health coverage means that the state would provide for medicines in the public as well as in the private sector. The consumer would pay part charges, a small amount of money, and this money would differ from one country to another country. So the price of medicine could be, for example, £100 or $100. You pay a contribution of $5, $7, $10, and the rest is being paid by the government. Government buy the medicine not only in public sector but also in private sector. So you actually supplied medicines through community retail pharmacies, but you have what we call it universal health coverage. And how governments select medicines, they actually do what we call it through the use of pharmacoeconomics, pharmaceutical economics. So they appraise it through the value of money principle. So there are many different sort of models which are used, and some of these models are cost minimization analysis, cost effectiveness analysis, cost utility analysis, and cost benefit analysis. One of the most common model which is used is cost utility analysis, in which you look at both quality of life as well as the quantity of life, and you look in the dollar values. So you say, for example, if you're paying $10,000, then this medicine would increase the X number of years in your life, 1 year of your life. But we not only look at the quantity of life, but we also look at the quality of life of the patients as well. So it's called quality adjusted life years, QALYs basically. So you say $10,000 per QALY or $20,000 per QALY. And every country has its own sort of standards. For example, New Zealand QALYs would be different from United Kingdom QALYs, or Australian QALYs would be different from other QALYs. But that's sort of the benchmark, but that's also another measure, because the single most important thing in pharmacoeconomics, that why pharmacoeconomics is used, is to decrease the price or to have a rational pricing structure by using pharmacoeconomics. So to give fair prices to pharmaceutical industry by appraising the real value of medicine. I hope that makes sense. So the studies have shown that in countries where the prices are controlled, affordability is better. So we have done a large number of studies, as I said, in many parts of the world, and we have seen that. And some of these studies which are actually I've quoted, this is my own work, original research work, which is being quoted in many parts of the world. So we have seen in the countries where the prices are controlled, affordability is better. This is a classical model, and I think this would sum up this whole debate today, that how prices are done globally, okay? Regulate the markets, control prices through, and most countries in the world except United States and few others, such as Malaysia, Philippines up to some extent, where the prices are not controlled. You have direct control, India, Pakistan, Bangladesh, and I'm going to work Nepal from next month with USAID, and they also have the similar sort of model. Indirect control with the government negotiation. You have compulsory health insurance such as UK, Australia, New Zealand. And interestingly, these countries have set up independent agencies to regulate the prices. So pricing is such an important topic that a separate agency is being set up. So for example, in New Zealand, there is an agency called MedSafe, which actually looks at safety, effectiveness, and quality of medicine. But then they also have another agency, which is called Pharma, Pharmaceutical Agency of Management Agency of New Zealand, which looks at only the pricing and access to medicine. The same way in United Kingdom, where they have MHRA for safety, effectiveness, and quality, and they have NICE, which is National Institute for Health and Care and Clinical Excellence, which is actually looking at access to medicine, affordability, and pricing. And Australia has done the similar thing as well, that they have two different agencies as well, because they consider it's such an important topic to provide for the millions of people that they have set up agencies, and these agencies employ hundreds of people to work on drug pricing or broadly access to medicines or public procurement. I hope it sort of makes sense about the topic. What WHO is doing in this context? So the WHO, World Health Organization, they're actively involved and they keep on working, providing guidelines, because as I said, many of the rich countries, they have the money, they can afford to basically pay for people, employ experts, but what about poor countries? So WHO do support and help and publish these guidelines on country pharmaceutical pricing policies, and I have been involved in many of these development of these guidelines basically. So I was actually asked as a consultant by WHO, so I've been contributing to develop these guidelines with WHO to look at pharmaceutical pricing policies. But there is a caveat with this. Though the guidelines are given, but it's not straightforward. You still need expertise at the local level, at the country level, to actually translate these guidelines into your local setting. And that's where the challenge is. Because what they would give you a generic structure, how to form. But every country is different. Every country healthcare system is different. I'm not saying that one country is better than other. It's just different because every country is unique. So the people are unique, customs are unique, culture is unique. So the healthcare system is unique as well. And the pricing model is unique too. So in this context, this makes it I found this is not an easy task for the countries to make their own pricing policy just by looking at it. It's available on the website. You're most welcome actually to Google it and download this whole report. This is probably a few hundred pages for if you would like to read through to give you an idea the kind of things they have suggested. So in a nutshell, forming a medicine pricing policy in a country is a challenging task. Countries are at different level of the health system, and these are interlinked because pricing is not a single isolated issue. It's an issue which is linked with pharmacy services. For example, we talk about extended role of pharmacist. You cannot talk about this extended role of pharmacist in UK without talking about pricing because pharmacists are being paid for the services. So I'm just giving you an example that pricing is not an isolated issue in a system where you have universal health coverage. So it's a linked issue together with a lot of other things. Okay, whether you talk about dispensing roles of pharmacists, or whether you talk about dispensing roles of doctors, or you talk about extended pharmacy services, you have this. Um, Western developed health systems are used as a guidance where pharmaceutical systems are inherently different from their own. So we follow through West, which is a very different model, and then we see what we are doing in Pakistan. Policymakers need to understand the pharmacy and reimbursement system of their own country before setting up a medicine's pricing policy. So the first step is actually to look at the reimbursement system before looking for setting up a medicine pricing policy. So, what are the objectives of a medicine pricing policy? The medicine pricing policy of a country needs to cover the following objectives, and it could be any country. It could be any country, XYZ, ABC, to ensure access to effective, safe, and quality assured affordable medicines for all, to establish fair medicine pricing mechanisms that can improve access. And the third component, which is in most countries, policies, you would see the third one, to support pharmaceutical industry. In some countries, this is not embedded. For example, in New Zealand's policy, you wouldn't see this third component, basically. But in most countries, you have these three components in place. Can I have some water, please? Yeah. So now, we're going to talk about Pakistan. As I said, the last year I was asked actually to develop Pakistan's medicines pricing policy. So I did, and we actually published an article as well. So some of the things, the guidance and empirical data which were available within the country, because we produced a lot of research. Thank you. Produced a lot of research because before forming a pricing policy, you need to have research, original research and empirical data which need to be available. And we have that in Pakistan context as well. And also need to look at what other countries are doing with similar socioeconomic status and what has worked in other countries. What has worked in other countries and what has not worked in other countries. As I said, the first thing when we want to develop the pricing policy for Pakistan is that we need to see the difference between Western developed countries and low and middle income countries. In United Kingdom, Australia and New Zealand, there is a public subsidy for pharmaceuticals, as I said, in both public and sector as well as in the private sector. And the government subsidizes the cost of medicine, and as a result, the private out-of-pocket expenditures for consumers are low. Whereas in Pakistan, this becomes a whole new level, where about 90%, if I'm not mistaken, 90% of pharmaceutical expenditures are being paid by the consumers, similar to around 90% to 95%. The rest is being paid by the government. So it's very slow. So medicine pricing does not impact consumer the way it does in countries where out-of-pocket expenses are high. And it differs from one country to another country. I can give you a very interesting example about China. So in China, at one point in time, public hospitals, they were actually selling medicines to their consumers and they were making profits, basically. So it differs so much. But then the government introduced the zero market markup pricing policy. And these are the agencies where I sit, which actually sort of set and negotiate the prices. So, for example, Pharmaceutical Management Agency in New Zealand, NICE in the UK, and often the value of new medicine is based on the cost effectiveness of medicine and quality adjusted life year, which I've explained is considered. The quality of life as far as the quantity of life. But I just want to point out that this is only done for innovative brands. This is not done for generics because there is no point doing it for generic. So the quality adjusted life years, and this is only done for innovative brands. This is a very interesting example. I wanted to show you this example that before 1993, New Zealand has one of the world's highest drug prices. So they were really worried. So they actually come up with a solution, and they actually set up this agency called Pharma. And since then, there are two lines here which you can see. One is a green line, and the below is the blue line. So green line is the one which are hypothetical pharmaceutical expenditures. Hypothetical. If they would not have set up this agency. And the blue line, the real pharmaceutical expenditures. And they have saved billions of dollars by just forming this agency. And what they do is they do these four things. So there are a lot of lessons to learn. They are monopoly purchaser. They are single purchaser of pharmaceuticals. They don't allow anyone else in New Zealand to buy pharmaceuticals from drug companies. They do reference pricing. And what is reference pricing? I'm going to explain in a bit. That they benchmark their prices with other countries. They do cost utility analysis. And the cost utility analysis, as I said, looked at both quality of life as well as the quantity of life through quality adjusted life years, and they heavily promote generic medicines as well. Okay, so these are the four things they do, and with these four things, they manage to keep their pharmaceutical expenditures basically low. But again, in this country, the consumer out-of-pocket expenses are very low. So whatever is being done, it's being done by the government. So if they're saving the money, they're saving the money for themselves. So it has very little impact on consumers, basically. Pakistan, India, and Bangladesh, they control prices for the same individual brand. Prices are uniformed and fixed, and the system has generated low prices in international term for these countries. So it's true, and I'm going to show you some of the slides as well, that in Pakistan we have reasonable prices, except few prices where we have high prices for innovative brands. And I'm not saying this from my head. This is actually coming from the original research work which we have done in Pakistan by using WHO and high methodology. So this was a time-tested methodology which was actually used. So what this slide is actually telling you that in countries where the prices are controlled, prices are on the lower level. So the real issue in Pakistan, in my opinion, is not the high prices. The real issue is the universal health coverage and the government funding and the public money which needs to go in. So I think, in my opinion, the political governments need to be transparent in telling the people what is happening in the sector. In Pakistan, there are significant out-of-pocket costs for pharmaceutical for consumers and patients. The MRP, as you know, is written on the medicine package, and they're uniform throughout the country and are set by Ministry of National Health Services, regulation and coordination. And you would be surprised to know that this system, because I give talks to all around the world, so when I explain this system in other countries, people find it very, very, they're really surprised to know about the system, that you have the single price throughout the country. Okay, because we went to Thailand, we went to Malaysia to collect pricing data, and the price would differ from one pharmacy to another pharmacy for the same molecule, for the same sort of things as well. So the people find this sort of system very fascinating, but it actually worked for Pakistan. There are empirical studies which were being done on Pakistan medicine pricing policy 2018, as well as some of the empirical work, which I'm going to show you. Several medicines are reasonably priced in international terms. However, there are others for which the prices are high. The majority of these high-priced medicines are innovative brand, though some of them are generics. The use of a cost-plus pricing formula has worked for Pakistan in the past to keep the pricing affordable for many medicines. However, with the emerging innovative medicine, this formula is getting obsolete. And the last line, it will be very interesting for you people to read the last line of this slide, that WHO has advised against using the cost-plus formula, basically. Because the thing, it has worked in the past. Many European countries have used the cost-plus formula in the past as well. But now this is getting obsolete. So the WHO has advised against using this formula because you don't have, due to transparency issues and things. We have done a number of pricing studies in Pakistan, and you can see that the prices of many medicines are within the range. And how we calculate this is done through using a methodology called WHO and HI methodology, World Health Organization Health Action International methodology. I'm going to take about a minute to explain this methodology. This methodology was developed at Harvard, and this is being tested in 50 countries around the world. And we did a lot of work by using this methodology in many of these countries, including Pakistan, Bangladesh, Malaysia, Thailand, and many other parts of the world. So what this methodology does, that they use a systematic random sampling technique. They collect data from community retail pharmacies, dispensing doctor sectors, and public hospitals as well. And they benchmark with international reference prices, which were obtained from an agency called Management Sciences for Health in US. So they have an international reference price indicator guide. So these prices, which are collected in a low and middle income countries, the median of these prices are benchmarked against the international reference price. In a nutshell, if the price of an individual medicine is more than one time in public sector, then it's considered not reasonable. And if it is 5 times in private sector retail pharmacies, then it's not considered reasonable. It's considered high price setting. So the studies we have done in other countries, for example, in Malaysia, we found that the prices were more than 100 times than the international reference prices, which were showing us that the prices were really, really very high. But if you look at in Pakistan, you would see that only a few blue lines which are showing you the prices which were around in 18 or 20 range. The rest, the prices were reasonable. So this is coming from empirical original research work which is being done by using WHO and HI methodology. And the blue lines are actually those ones which are innovative brands. So innovative brands are the ones where you have patented, where the first time a company would manufacture. So in a nutshell, most generics which are being produced in Pakistan are reasonable in international terms. So what Pakistan needs to do is actually to work on some of the strategies where you see that innovative brands are really, really high. And in Pakistan, this is why this impacts, because 90% of the consumers, and you may have better figure than me, which are paying out of pocket. So we have huge expenditures on pharmaceuticals. Normally, pharmaceutical expenditures in high-income countries are about 20 to 30% of healthcare budgets. But in Pakistan, it's more than that, because we spend less amount of money on primary healthcare. We spend less amount of money on public health, protection and things, and we spend more money on secondary healthcare or tertiary healthcare. So more money is being spent when people end up in the hospital. That's why our percentage on expenditure, in percentage wise, we are on the higher side, 60, 70, 80%. And this is in most low and middle income countries, not only in Pakistan, but many low and middle income countries. We actually see the similar sort of phenomena. So what is the solution for Pakistan's high prices? It's critical in this context to analyze and explore prices of medicine case by case basis rather than applying a bracket formula. So we need to look at it empirically and apply rather than putting a blanket sort of formula, especially for innovative brands. And we also, when Minister asked me to work on it, so I also did an analysis of 2018 pricing policy. So actually look at how the prices are being, done. 2018 Pakistan's pricing policy measured the average retail price of a basket of countries including Sri Lanka, Indonesia, Malaysia, Bangladesh, and Lebanon. Prices in Sri Lanka are low. However, other benchmark countries, including Malaysia, Indonesia, they have some of the highest prices in international terms. And I spoke with the ministry that how come you could actually come up with a country like Malaysia? How can you put this country here? Because this has one of the world's highest prices in international terms. Even Malaysian prices are higher than Australian prices. And again, this is coming from the studies which we have conducted. Bangladesh has reasonable medicine prices, but this also needs to be looked at case by case basis. In 2016, I was appointed by World Bank to actually work with Bangladesh to set up their medicines pricing policy as well. 2018 policy also uses the average procurement prices of the Australian Pharmaceutical Benefit Scheme and UK's drug tariff prices as benchmark. This is again questionable because in developed countries, Australian prices are considered on the high terms. If you actually look at the developed countries' data, especially for the innovative brands, they're considered on the higher side. So this has the inclusion of Australia and UK as a benchmark for Pakistan is challenging, and I can explain you why it's challenging basically. For what were the reasons that why it's not going to work. Australia and the UK all practices universal health coverage with part charges from consumers and no out-of-pocket payments from marginalized section of society. On the other hand, Pakistan has significant out-of-pocket payments. Another challenge, drug prices that are listed price from Australian PBS and UK drug tariff in the public domain may not be the actual prices, basically. So even if you want to benchmark the prices with these countries, they're not the real prices. The published prices could be discounted prices after rebates by a pharmaceutical company. And another thing is that Australia has high prices for both innovator as well as the generics. And in both cases, they have very high prices in international terms. So when you look at Pakistan's pricing policy 2018, I've given you some example that some of the countries which are being listed, and I have analyzed it scientifically, that why it's misleading and wrong to include these countries in these settings, because it wouldn't make sense basically to include this data. The best way to form a pricing policy in a low and middle income country is by taking into account the data obtained from studies using WHO and high pricing methodology. As I said, the prices and availability of innovative brands and lowest price generics are measured in more than 50 countries. It provides room for profits for the pharmaceutical industry. At the same time, it advocates a rational pricing structure to promote affordability. The methodology compared the median community retail prices for both public procurement with the international reference prices. And when you actually compare IRP's international reference prices with community prices, a median price ratio is obtained, which is called an MPR, basically. And this MPR would be able to give you universally for a single brand whether how high or low your price is. So I can give you an example, for example, Losec, omeprazole. So for the Losec brand, you can benchmark the same price for Pakistan, for Lebanon, for India, and you can see how high or low in international terms. So we compare apple with apple and oranges with oranges. So 20 milligram with 20 milligram. We don't compare 20 milligram with 40 milligram. So you have to be exact, the same. You can compare generics with generics of the different brands, but you cannot compare the innovator brand with the generics, because that would be wrong. So we compare the same with same. It would give you fantastic data throughout the world that where your country stands in terms of the global medicine pricing structure. And then you can build in strategies and interventions to bring down the prices or bring up the prices. So a median price ratio, as I said, could be used as a guide to benchmark prices in a low to middle income country, how high, low, or should be in a given context. MPR of about 1 is considered reasonable in the public sector, or about 3 is considered fine in the private sector. It considered taxes, markups, profit margins for the pharmaceutical industry growth, basically. So that's the kind of approach. Because whatever we suggest, we have to have reason. With the pricing, we cannot go with our thinking or wish list. Because I'm in good mood today, I would like to give this price. No, it doesn't work that way. Okay? So you have to have a scientific basis to apply, and that's why these countries, they have set up scientific agencies to work on prices through value-based pricing. So some of the prices where I found were high in Pakistan from the empirical studies, and I'm not naming the brand names, and there is a purpose that I'm not naming the brand names, because I have nothing to do with the specific industry. It's just on the basis of a scientific discussion that some of the innovative brands in Pakistan, acyclovir and torvastatin, were 18 times higher than IRP. So they were on the high side. Ciprofloxacin, ceftriaxone, diclofenac sodium were 15 times higher. Fluconazole was 60 times higher than international reference price. Omeprazole and simvastatin were higher, 12 times higher. And most of these were innovative brands. Okay, so they were all from big pharma. These medicines and others are commonly used by Pakistanis, and this is resulting in significant out-of-pocket payments, impacting affordability. So perhaps extensive, detailed exploratory studies further needed to scope out these medicines. So what is the suggestion? I mean, coming up with this ground sort of analysis for Pakistan. So we have to come forward. What sort of policies we could suggest? And as I said in the start of this presentation, that basically when you talk about a pricing policy, you don't talk about a single policy. You talk about a mixture of policies which work together to actually form a policy. Multiple pricing policies to achieve low prices for medicine. The WHO has also recommended this approach. These policies, and I'm going to explain in the next few slides what these policies could be. Internal reference pricing, external reference pricing, value-based pricing, and markup regulation. So when we say medicine pricing policy in a country, we say combination of all these policies. Whether it's a value-based, whether it's internal reference, whether it's external reference, and markup regulation. WHO advises against use of cost pricing, pricing formula. However, if you need to use it, all costs and prices needs to be transparent. Sorry, this is not a very clear slide, but you can actually look at on this article is my published article. So if you actually Google Journal of Pharmaceutical Pricing Policy or Pakistan's medicines pricing policy with my name, this article would come up in Journal of Pharmaceutical Policy and Practice, and you can actually download the whole article free of charge. And this would give you this table. It's not coming up very nicely, but in the next few slides, I'm going to show you what is listed in this table. Cost plus pricing policy, which is being used in Pakistan, requires significant technical and human resources. The most challenging part of cost plus is obtaining and validating information on different cost components. The lack of transparency in expenses on pharmaceutical marketing also makes it challenging. Some of the countries which has used cost plus pricing are Vietnam, China, Sri Lanka, Bangladesh, Iran, and Pakistan. So Pakistan is not the only country which is actually using cost plus. There are other countries as well. India and Colombia has discontinued applying cost plus pricing. In the past, European countries have used a cost plus pricing. However, at present, no European country uses this policy anymore. So previously they have been using, but now they're not using cost plus formula. External price referencing. This is again a very common sort of pricing method. And this is used all around the globe, whether it's New Zealand, whether it's Australia, whether it's Pakistan, whether it's any part of the world. External price reference is also called sometime external reference pricing. Medicine prices are set on the prices of the same medicine in other countries, and people try to look at the countries with the similar socioeconomic status. And then the benchmark their prices with those countries with the similar sort of models and socioeconomic. Commonly used new medicines likely to reduce the prices of medicine. It includes all forms of discounts, rebates, taxes. It is recommended to apply external price reference at the level of the ex-factory price level. Pakistan can use and apply external price reference by benchmarking with countries such as India, Bangladesh, Sri Lanka, South Africa, Iran, and New Zealand. India, Bangladesh, and Sri Lanka are all South Asian countries with similar socioeconomic. New Zealand you could also use as a benchmark because it has some of the lowest prices in the Western countries. You can just use it as a guide. And again, these countries, these I have suggested, and I've listed this in the article, are based on the scientific evidence. There is another sort of pricing policy which is also used, which is called internal reference pricing. And internal reference pricing is mostly used for two types of products: generics, where you compare two generics or biosimilar, or therapeutically equivalent medicines. So for example, a medicine within the same class. For example, you could have two beta blockers or AC inhibitors, and you can actually sort of, benchmark the prices. A specific type of internal price reference is called a generic price link. This policy refers to the practice of setting the price of generic in relationship to the originator, usually at a certain percentage lower than the originator price. Is also specifically useful in the absence of demand-side measures to encourage the preferential prescribing and dispensing of multiple-sourced versus originator brands. But it depends what is the price of originator brand. Then you can see that you would like to go down this much for a generic medicine as well. In Pakistan, the first generic could be priced 40 to 50% below the originator. But again, this is debatable. It's just a suggestion here. Whereas the price of first biosimilar could be reduced to 30%. However, these are suggestions, and other pricing models could be explored. For example, in Austria, Greater price reductions have been seen in the case of generics. Successful drug switching can be seen for statins in Netherlands. And again in Pakistan, I'm a great advocate of use of generics. I don't consider generics as counterfeit or low quality. I consider them good quality medicines, and I think they can be used more to achieve greater savings and to improve affordability and access for Pakistani consumers. Value-based pricing. Value-based pricing is a very interesting concept, and I don't think so we use it in Pakistan. But I want to tell you that many other countries, which are developing countries, they are using value-based pricing. They have set up their units. So for example, in Thailand, the Thai FDA has set up a special health technology assessment unit for new innovative brands. And the value-based pricing is use of health technology assessment, basically. Highly specialized task and needs a health economics unit together with input from pharmacists, clinicians, evidence-based practitioners. And it can specifically used for high-cost medicines and innovative brands. So for example, in Philippines, they have set up a unit called PhilHealth because to look at the price of these medicines. Pakistan can take a gradual stepwise approach to develop legislative and technical capacity to implement value-based pricing using health technology assessment. I don't think so we have health economists, in my understanding, at the Ministry of Health or at DRAP who can actually work on value-based pricing. And it's a expensive exercise. It's not an easy thing to do. Okay, the developed countries, as I said, which employ value-based pricing, they have whole independent authority which are working in this context, basically. So in value-based pricing, I just put some of these models which you use in pharmacoeconomic analysis and minimization, utility, and cost benefit. And most of the time in pharmacoeconomics or value-based pricing, you use what we call it cost utility analysis, where you have dollars and then you have quality adjusted life years, QALYs, where you look at not only the quantity of life of the patients, but also look at the quality of life of the patients as well. Cost utility analysis compares net cost against net health outcomes. Net costs are compared to net health outcome. For example, a medicine listed Y cost utility analysis, tamoxifen for the primary prevention of breast cancer. So through value-based pricing, many medicines were actually rejected in developed countries, though people would like to get new medicines, but because they couldn't prove the value for money models, so they were not being bought by the government, because you cannot justify the value. This is very interesting, just to give you an idea, the threshold range in Australia and UK. So in Australia, a new drug with a cost less than $50,000 per QALY gained is more likely to be recommended for funding. If it is more than $50,000 for QALY, QALY is quality adjusted life years. So 1 year of life, which is of good quality. So good quality means that the patient may still die, but that 1 year, they can actually live a good productive life without pain. So if you give that medicine, so it means that $50,000 per patient is fine. But if it goes more than $50,000 per QALY, then the Australians wouldn't fund it through the public health system. In NICE, it's a different threshold, and it's about $20,000 to $30,000 per QALY, pounds per QALY for normal drugs, and 50,000 pounds per QALY for drugs at the end of life, okay, where people are actually dying. So the different countries have different sort of value-based pricing, but these are some examples of value-based pricing in which you have cost utility analysis or quality adjusted life years are being used. The use of value-based pricing is questioned in low and middle-income countries. There are some lessons to be learned. For example, in Stockholm, in Sweden, has successfully operated a limited list of 2,000 essential medicines covering over 90% of the needs in ambulatory care. This approach has been very effective to promote the rational use of medicine. This also begs the question that why do low and middle income countries need new high-priced medicines when patient in ambulatory setting can be well treated with a smaller number of medicines. And we have seen this in Scandinavia again and again, and if there are any clinicians here, there actually you can treat majority of the diseases with a smaller set of medicines as well. Okay, so there are pros and cons of using value-based pricing. I'm all for it, but for that we need huge resources for a country like Pakistan. So maybe pharmaceutical industry, if they're interested, maybe they can actually come up with a research unit to actually work on health economics or come up with some sort of a unit on value-based pricing, because I think sooner or later this is the destiny, this is the future for Pakistan. Markup regulation, this is again a question for debate and discussion, that what sort of markup regulations would be okay. 15% is applied, wholesaler and retailer in Pakistan. This is fine for medicines that are rationally priced. However, there's need to develop a aggressive markup structure in which the markup rate decreases as the price increases, because we have seen for some medicines in Pakistan, which are innovative brand, they're highly priced. So you can come up with a aggressive markup structure. Transparency is needed when setting up markups along the supply and distribution chain, including disclosure of rebates and discount. There is a need to encourage early market entry of generics and biosimilar through legislative and administrative reforms. So the proposed medicine pricing policy structure for Pakistan is that a snapshot of suggested pharmaceutical pricing policy. So the snapshot include external reference pricing, and I've given you some countries, internal reference pricing, value-based pricing, with some sort of markup structure with benchmark countries, including Saudi Arabia, South Africa, Bangladesh, Iran, India, and Sri Lanka. For Me Too medicines, a cost minimization analysis could be done, and it could be also encouraged. And again, these are suggestions open for further discussion, but this is again based on empirical data, research, scientific advice. For the new presentation, the same medicine, dosage of medicine already marketed, the price should be worked out based on arithmetic mean of the prices of previously launched medicine. It is suggested that the price must not exceed the average price weighted by sale of available presentation of the medicine that have the same active ingredient, strength, or dosage form. Generic medicine should not exceed 40 to 50% of the respective reference price. So again, this is for further debate and discussion. So based on this, what are the recommendations for the future for Pakistan? The decision to formulate and set prices needs to be based on empirical pricing studies. Hence, ongoing research is needed in low and middle income countries, including Pakistan. So we need to have continuous research, and this is also vital because of the current financial position we have in Pakistan and devaluation of dollars and things. WHO has provided guidelines to form country pharmaceutical pricing policies. However, translating them into local setting is a complex task. Educate human resources and skilled personnel are required for implementation, monitoring, and ongoing evaluation of medicine prices. So sometimes I get consultation requests from people like ministry and others, and they wanted me to work on pricing, and I do. But people need to understand it's a time-taking task. It can't be done in a one-off meeting. So it's a continuous process of learning and implementation, which requires a specific team skill set where I'm happy to provide advice and support. A center for evidence-based medicine and pharmacoeconomics should be established within Pakistan. We currently don't have it in any of our pharmacy schools or in any of our medical school. So this is a suggestion I would like to give it to the pharmaceutical industry as well, if they would like to have some efforts, or to the ministry. I've spoken with the ministry last week. I was at the Ministry of Health at DRAP. So some of the suggestions have been given to them as well. Pakistan also needs to undertake a regular price revision at the pre-specified frequency when using external reference pricing. So these are some of the recommendations for future. So thank you very much for listening. I hope it was a long talk, and pricing is not an easy topic to understand. It's a complex topic, and I consider myself as a student who has been working on pricing for the last 18 to 20 years in this field. I'm happy to take any questions if you have. Thank you very much. Yes, there are one
Dr.
here.
Saab.
Yeah, well,
Thank you very much for a lovely presentation, very informative. Just what are your views on one molecule, one policy, or one price for Pakistan?
I think I've given my views. I think it has worked for a country like Pakistan. That actually you have this the same price, whether one molecule you mean one brand or you mean a different brand.
One generic. One generic. Yeah.
The innovator has one price, and then as per policy, actually all generic brands for ciprofloxacin should have one single price. But it's actually different. I mean, people have different prices. It's not that we fix that MRP. It's DRAP who's fixed different MRPs. So that's what he's talking about. It should be same across the board.
It
As
should
per
be
your
same across.
presentation,
Yeah,
it is same, and it is as per policy, but actually it is not.
Yeah. So that's more sort of an implementation issue rather than a conceptual issue. Yeah.
Dr. Saab, why WHO has advice against cost plus policy?
The reason to not
Because
to use
it's being
cost
observed
plus,
in Pakistan.
Yeah. The reason to not to use cost plus is basically the transparency issues in cost plus. The reporting of raw material, reporting of all these, it's problematic. It's not easy that you get the single thing, how much this raw material cost and how much this raw material cost. And from my own experience as well, I mean, sometime I meet with people and they wanted to do studies on raw material. There are no pricing studies on raw material. That's never done anywhere else in the world. So nobody does it, basically. So that's why it's not advisable to use cost plus, because of the transparency issues. And again, I'm saying if we have to use it, then we have to be very transparent about each and every sort of ingredient, I would say.
Thank you, Dr. Babar, for such a wonderful presentation. I mean, you pointed out this in the end, but I mean, this is an issue which is very pressing currently and very relevant. How do you see the pricing mechanisms working and the longevity of that policy when we are dealing with an economy that's characterized by such a volatility and such dollar fluctuation over such a short span of time? And I have a few more questions if audiences could bear with that.
Yeah. No, thank you. I think this is a very sort of relevant question. And if you look at my slides, which I presented as well, I've asked for the continuous price monitoring. You could see that actually in the slides I've listed that we need to continuously monitor the prices. And this is the answer to that, because I think we have challenges like many other low and middle income countries. What other low and middle? But on top of that, we have our own challenges as well. So that makes it more challenging. Pakistan as a country more challenging, because when the dollar value against Pakistan rupee, there is a lot of inflation. So, but I think whatever you do, these pricing principles wouldn't change. Okay, again, and the mechanism, you can adjust the mechanism, the principles wouldn't change, and the purpose is not to penalize the industry. The purpose is to have a rational, balanced pricing structure where you have a profitable pharmaceutical industry, but at the same time, the interests of patients are also protected. I think that's the kind of balance which we are trying to acquire. The principle will be same, but you can adjust the markups, you can adjust the things, and with the dollars and things like that. But that's only possible if you have a unit which is continuously monitoring it. Because one study of pricing, it doesn't mean anything. You do one study on pricing, it's relevant at that point in time, maybe a year or 2 years. You need to repeat that at a continuous step. So what is happening in the country, basically?
And Dr. Babar, what's your take on this idea where you have said that the industry should not be penalized? Do you think in the current situation the industry is being penalized, whereby the government is actually allowing certain sectors to set their prices on terms of free market principles, and the pharmaceutical industry is being regulated so stringently? So what's your take on this?
I wouldn't comment the comparison of pharmaceutical industry with other sector, because I think I've explained in my presentation as well that Pakistan is not the only country where the prices are controlled. There are other countries as well which do control prices. And price control, in my opinion, is not a bad thing, because when you control the prices of sugar, when you control the prices of flour, the price of drugs can be controlled as well, because they're essential items. As in United Nations Human Development Goals, it's access to human right. Access to medicine is a fundamental human right. That's one. Number two, medicines are not like other commodities. Medicines are not commodities which you can go and directly buy. Of course, you can go and directly buy in Pakistan, but in other countries, you need an intermediary. And that intermediary is a doctor. If you like a shirt, you go and buy your own shirt. If you like the shoe, you go and buy your own shoe. For medicine, if you need a medicine, you go and see the doctor. So there is a third person involved in this whole setting as well. So the debate is much more complex. When I say the penalized, I didn't specifically use it for certain, but I think in the current environment, we need to be transparent. When the politicians say the prices are too high, I think they may not be justified, in my opinion, because I've shown you the actual figures, I've shown you the actual data. For the politics, maybe it is good that we say for the politics, but for the actual science, I don't think so, because this is the actual science which I've shown you with the worldwide comparison. Yes, we have high prices for some drugs, for some innovators, but not for others. So we need to distinguish the medicine to medicine, and we need pricing interventions for innovator brands. Where the prices are low, we need to give them good prices.
Thank you
Is
for
it
your
okay?
thank you. Yeah, thank you for your reply. And would you agree that, I mean, as you have said, the situation is rather more complex, and in terms of pursuing the agenda of equity and fulfilling the objectives of the health system, I think Pakistan needs to invest more in financing and working towards universal health coverage rather than just pinpointing and kind of working.
We need to invest more money in universal health care. We need to invest more money in public sector hospitals, providing free drugs or low-cost drugs. Low cost doesn't mean bad, because to me, any drug which is registered with Drug Regulatory Authority of Pakistan, they need to have the basic principles of good quality, safe and effective. These three needs to be fulfilled. Otherwise, don't register it, in my opinion. So the government needs to invest more. I have not studied in detail SAS program, though I know Sani Nishtar, she is on my journals board. But I think similar sort of models where you could invest and pay more money for pharmaceuticals, where you can actually support the lower sectors of society. Rather than saying prices are high, we need to give more money to these people so that they can buy medicines. And again, in one of the slides I've shown you that even giving low-cost medicines does not guarantee that people will actually take those medicines. Some people, we given free medicines, they don't take it. Compliance is a big issue. That's another part of the debate. So when in Africa and Central Asian countries, when the World Bank, WHO, they started programs giving them $1 per cost of treatment to the patient, some patient didn't take it. So the outcomes, patient outcome, because the reason we have this whole debate, we want the better health for the patients, basically. But in some countries, of course, we have these challenges. So we face multiple set of issues and multiple challenges when we need to invest heavily in the pharmaceutical sector, and the government needs to proportionate the public expenditure on pharmaceuticals.
Dr. Saab, can I ask a question?
Sure.
I am Kaisar Vaid from PPMA and Medisure. There is a debate and a concern that due to our price structure or price policy or heavy control, since 1976, that Pakistan pharma industry is not encouraged to go into the developed world and market their product or provide as our neighboring country is called pharmacy of the world, and we see that they are going to be within 2040, they're going to be having $100 billion pharma market. What do you think this price control, heavy price control, or is hampering in the way of progress of the pharma industry?
I think the prices are linked with the growth of industry. This may be true to some extent, but not maybe all, because I'm not sure what India has done. India is a big country with 1 billion people. They have a bigger infrastructure. They have better linkages with Europe and United States. They have better diaspora who is working in Europe and United States, who are actually giving technology transfer and all that sort of things. This could have helped to have a better pharmaceutical industry. They do have a price control, and Indian prices are also one of the lowest in the region. Having said that, I just also have a counter question, basically. How many new drugs India have produced? How many new molecules India have come up? They have, of course, they have a world share in generic industry. They have Me Too products. They have biosimilars. But have they actually produced a new molecule? Have they synthesized a new molecule? Japan has. They have their own pharmacopoeia. European Union has, or US has, but has India has, or China has. What they do is actually they have Me Too products, or they have, of course they contribute, and it does matter, but they could have done better as well, but unfortunately they have not produced a single molecule.
Another question, probably may not be placed over here, but I think that in India or anywhere in the world, basically in US, academia really help work with the collaboration with the pharma industry and work for to find out new therapeutic modalities for the ailing humanity. But in Pakistan, unfortunately, academia is, unfortunately, there is no collaboration with the any industry, not pharmaceutical, but just. So maybe the reason with that pharma industry does not have that much of cash to invest on the project which endeavoring by the universities.
Yes, this could be another reason where you see that, and I think this could be vice versa. You have pharmaceutical industry, and then you have academic organizations, and whether the meaningful research is being done, and whether this research has translated into anything. Because research in Western world now, they look at the impact. And impact, if you give me 1 minute, I can explain. Impact is basically that if you're doing research, what would be the impact? Whether it's producing a new medicine, whether it's producing a new biosimilar, or whether it has an impact on patient health outcomes. So if I'm producing the paper, of course somebody is doing PhD or masters or whatever is it, but that doesn't stop there. It actually starts from there. So how it impacts on a community, how it impacts on people, how it impacts on patient behavior. So in research, the Western societies, Western funding institutions, Western universities, the Western UK government, they work together very closely. We think that they're isolated institutes. It's not. They work very closely, whether it's university, whether it's academia, whether it's research organization. And the single goal is to produce research impact. Producing a paper is fine, but what after that? You just produce the paper and throw it away? No. I think it starts from there. You read the paper and apply it in sort of applied sort of research. Again, I think Higher Education Commission has a big role to play here, because I think they can develop I'm sure they would have interest to develop industry and academia linkages. Again, I'm aware of you would know better than me, there is an industry fund as well, where you pay 1% of the charges, or 0.1%.
CRF.
Yeah. So I think these sort of things, and again, I'm not expert I'm not very of the details of that fund, but I think some of these models could be used. But the most important thing for me is the selection of research projects. I think that's where the whole thing starts. You need good research team, but on top of that, you need good research topics, meaningful research topics, which can make a difference. And the research doesn't start after you publish the paper, it starts when you select the topic. So I think the major challenge we have is basically maybe to organize a symposium with academia, inform them of your issues, listen to them, and then come up with maybe 10 research topics where they can guide you or you can guide them, vice versa. And I think it's a learning experience, learning from pharmaceutical. Academia also needs to learn from industry. Academia is not, if they're not at the top, they need to learn from industry. And if they have any sort of things, they can also learn. It's a vice versa thing, because it's a lifelong learning process, basically.
Just one, I think more or less it's going to be a suggestion. I personally feel that as IT industry has progressed with the help of venture capitalists, if we form a sort of a troika, academia, industry, and venture capitalists, and venture capitalists fund fulfill the need of pharma industry through academia research, it can be possible. But as you know that in Pakistan, venture capitalists are not much available as in the developed world. Even in India, I know there are many venture capitalists have emerged, and they are helping projects. Biocon has developed biosimilars with the help of venture capitalists. Even in Pakistan, if venture capitalists can evolve and help because a lot of money, universities are waiting for the funding from the HEC or any donor agency to help their projects. And there is no proper monitoring of those projects, even that whether that project can turn into the helping the humanity needs or whatever.
I think this is an excellent suggestion, Kasab, from you. And as an entrepreneur, I think as an entrepreneur or business person, you may look at the modalities that what could work out, basically. But I think maybe a team is needed who could look at those sort of research projects which could be useful for industry, but could also be useful for academia as well.
So according to recent pricing policy, which was approved in 2018 for Pakistan, the prices are revised annually on the basis of consumer price index. During a series of meetings last year with the Minister of Health, for which you were referring, so they were not comfortable on this way of revising the prices. So what are your views on this? Because this was established after taking into confidence all the stakeholders, task force, and it was, very, very, you can say, analyzed deeply after, formulating this pricing policy.
I think the pricing structure which I have suggested was based on WHO and high pricing methodology. So I think a revision of any price, we need to look at first that whether that price is really low or high. And if they are low, then of course they need to be given them appropriate price. The major issue we have is that we need to form a scientific basis. So whether you go for a consumer price index or whether you go for any other price index, it needs to be a formula which is acceptable for both parties, pharmaceutical industry as well as the government as well. And I think the generic sort of things which I've given it to you, it forms the basis. So this was the pricing policy which I suggested to the minister. He was having it, but then we have a government change. So that doesn't go anywhere, basically. So we do work on these things, we do provide suggestion, but I think political situation in the country is the sort of key in this whole thing.
This is Kinza from Pharmatech. My question is, since you have mentioned that WHO is not advising cost-based pricing and most of the European countries have discontinued it, for the Pakistan case, how would you address or what would you advise to cater the cost factor in pricing policy in Pakistan? Because this is a main factor. Obviously, if you import a product or manufacture locally, the RM plays the main role. So how would the cost factor would be addressed if we do not consider the cost factor in pricing policy?
Yeah. Very good question. I think there are two parts of your question, whether how do we do that. The first thing, why European countries are not doing it, because I have shown you that they are considering value-based pricing, value for money, pharmacoeconomics, and they have whole setup and units to do that. So they're going for it because they have an alternative to go for it. Coming for your first question, in my understanding, Pakistan has not completely abandoned cost plus. They are still using cost plus pricing. Well, what I was trying to say is that we need to be more transparent if we are looking at the different components of the cost, basically. So we need to be more transparent. In future, WHO they do not advise because the reason behind, because of the transparency issue. Transparency is a big issue. And as I said in the last phase of my presentation, for Pakistan as well, the future is value-based pricing, but we do not have resources. So again, my plea to the government would be, and also to pharmaceutical industry, which is a very important stakeholder in this country for patients and for healthcare professionals, is actually to work towards the value-based pricing, where you could show the value for money. But again, value-based pricing is only done for products which are innovative brands. We do not do it for generics, because generics are already low priced. So it's already done for innovative brands. So I'm not sure what would be the industry interest here, but maybe big pharma interest could be there in this context.
Okay, thank you so much.
I hope that helps.
Assalamu alaikum. I'm Dr. Anjum from Woodward Pharma.
Yeah.
I would like to ask your opinion. When there is no health policy across in our country and DRAB strict policy on pricing, how it can be a part of our population can be benefited in Pakistan.
Can you kindly repeat your question? You are saying that when we don't have a health policy
across
Pakistan, then how could we have a pricing policy?
And DRAP has a strict policy on price increasing. So how can the major population of Pakistan can be benefited?
I'm not sure about the existence of a national health policy in Pakistan. I know I worked on a national medicines policy, which was different from pricing policy. So medicines policy was a different policy. Again, I worked with the Minister of Health, Dr. Zafar Mirza. He invited me to come to Pakistan, and we worked on 15th draft of that policy. I still have it with me. And one component of a national medicines policy was actually to promote access to affordable medicines. So that was one of the single component. And that's again, WHO has a national medicines policy, and all countries in the world, whether it's UK or whether it's Pakistan, they follow through that policy with a generic policy, and they implement and change things, and then they follow through. But in many countries in the world, there is no policy. But it doesn't mean that the people are not getting medicines. They have a fragmented policy in different shapes and forms. I can give you an example of a country called Qatar, which is a very rich country. We worked on it quite a lot on the policy. They don't have a single integrated national medicines policy, but the people have access to affordable medicines. They have smaller policies which work for the people for different sectors. So it's good to have a national health policy, and I'm not Pakistan's overall health policy expert. I'm more of a medicines, pharmaceutical persons who work in national medicines or pharmaceuticals or pricing sector. So I think it's better to ask someone who has more expertise at the health policy level. At the broader level, how do we look at things? We have produced a lot of literature in Pakistan in the last 20 years in pharmaceuticals, not only in pharmaceuticals on access to medicine pricing, but also in health sector. So I think people maybe at Aachen Hospital, they could be at the forefront of health policy. Where do they see this? Whether they consider this? Because the pharmaceuticals, I know they are important component of healthcare. Why it's important? It's not important because I'm a pharmacist. I'm not saying that. It's important because in developing countries, 60% to 80% of the expenditure on on health are pharmaceuticals related. That's why nobody can ignore pharmaceuticals, basically. So it has to be in, and it should be in. And if it exists somewhere, somebody can enlighten me. It should be part of the health policy of the country. And I'm sure it should be somewhere in the documents. Maybe it's old, but it should be somewhere.
Okay, thank you very much. Thank you.
1980 health policy. Kaisa bhai sab saying. Maybe there could be some update. But I think we have produced a lot of literature in health. We have produced a lot of work in pharmaceutical. The only thing we have is how to use it. Often producing the research is one step. How to use it. I can give you an example of a country, Malaysia, where I've worked a lot. I've worked for 10 years there. There are thousands of papers in Malaysian pharmaceutical sector, but it's not implemented. It's not implemented. So we don't know how to use research. So the country has stopped at a certain level because you're not using research. So if you're not using research, what would you do doing further research except producing masters or PhD? There will be no other role because health sector would not develop. It will not progress. Having twin towers in the country or better roads, it does not reflect the country's development. To me, if you have a dispensing doctor sector, if you have a health sector which is advanced, that is more sort of that would more sort of show the development in the country.
Dr. Babar, I'm Mubin Khatri from Searle. Basically, I'm looking after the pricing parameters of the company. I have observed two things in the last two different policies. One is the pricing policy in 2015, and then the revision in 2018, and then bit amendment in 2020. Mm-hmm. This policy, I say it's a very good policy. But at the same time, I have feel that there are a number of provisions on which applications sent to the rep, and they don't consider the actual timelines and other things. Like in CPI cases, Consumer Price Index, they last issues the only 2020 letters, and then there is a delay. Then in hardship cases, we have faced a lot of issues, problems. Even the things written in the policy, that after this much days, after this reminder, one can implement the price. But even then, so I reached to the point that policy is very good, but the issue is with the implementation. Can you enlighten this issue in respect to the Pakistan policy?
Yeah, I think you may rightly pointed out. I've seen some of the challenges and loopholes in 2018 policy, and we have suggested it. But implementation is at another level. This is what I was saying in terms of implementation. When you produce a lot of research, but it's not implemented. So implementation only comes with political commitment. That doesn't come without political commitment. I can give you an example of a country called South Korea. So basically, 15 years ago, the South Korea, the government said that doctors would not be able to dispense medicines anymore. Dispensing would only be done by pharmacists, not doctors. So the doctors were a very powerful community in any country in the world. So the doctor went on strike. The government said, you can do whatever you like, but we would stick with our decision. And the dispensing rights were taken from the doctors and given to the pharmacist. This sort of thing can only happen with the political commitment. So in terms of your implementation thing, I think that can only happen with the political commitment. There is no other way out. It has to come from the top. It doesn't go from the bottom. Anything which we have seen change in the countries, they always come from the top. President, Prime Minister, the top executives of the country, they bring the change, not the bottom level, basically. In 2008, I published an article in my journal on Thailand and Vietnam pricing policy. So it went into the Prime Minister of Vietnam. They changed the policy, basically, on the basis of one article. We produced article, we think we're producing article just for masters and PhD. The articles are being used to change the destinies of whole countries, basically. That's the real reason. So I think implementation, you need understanding how to implement it. What are the reasons why it's not implemented? I wouldn't go into it, whether it's bureaucratic or some of the other administrative things, but I'm sure there are enough competent civil service bureaucrats and health policy experts in this country who can take this further.
As you do global research, so I would like to know what are the steps being taken by India, Bangladesh, or other price-related countries to deal with current global inflation and to ensure that there is no shortage of products in their countries. As you can see, the global inflation nowadays. So, what are the steps industry or the regulators of their countries taking in order to make sure that their medicines are not being shortened in the country and the industry is also doing their work at the same time? So what are your views on that?
I think maybe it's my feeling that in Bangladesh or India, industry may be supported a lot by the government. And especially in Bangladesh, a lot of incentives been given to the industry for the export market. Another thing which has helped Bangladesh, there is a status called TRIPS Plus. So they can violate TRIPS Plus because Bangladesh was classed as a least developing country. So till 2020, they were considered least developed status. So least developed means that they can violate patents. So they don't need under WTO paragraph 6 of Doha Declaration. They can violate patents as a least developing country. I think they have this advantage. And this TRIPS Plus provision is still there. So when you can violate patents without having fear of any litigation or things, then of course you can go on. But I do understand they have support. Their pricing structure is very similar to what we have in Pakistan, but they may have, support for exports and things like that. I have not studied in detail, so I cannot comment more than that. Thank you.
How can we control hidden discount, which is given by the industries to the distributors, to the medical stores, or even to the doctors?
I think that's again an administrative issue. How do you implement it? And again, the same thing. We have the laws, but how do you implement it? So it's the same thing when you have schedule that you cannot sold antibiotics at the pharmacies without prescription, but you can literally buy antibiotics. So I think it's something similar to that. So how do you do that? That's another question, which I don't think so. I can provide a broad policy level answer to the things, but how do you actually do it? That's the decision maker in this country. They need to figure out how to do it.
Assalamu alaikum. Babar bhai, Shamim Raza from Aahan. I think, first of all, lovely talk and very enlightening to see, the global perspective and the pricing structure of the different countries and regions. मेरा बड़ा सादा सा सवाल है एंड वो सवाल ये है कि इस पूरी प्राइस की वॉर में the consumer is not getting the medicines. And there is no one is basically talking on that point of view. Access of the medication, how can they get the access? There are a lot of things related with the profit and the business. whether it's a pharmaceutical company, which is a national or multinational, everybody is looking around their profit and selling. Multinational companies in Pakistan are either acquisitions, mergers, ja rahe hain. So how can an innovators can come to fit into that value-based model which you talked about? National essential medication की list हमारे पास भी आती है for review, for AQH. Let's say just put that review, but we don't have certain seras available, which are the life-saving things. Tetanus toxoids is not available in the country since last many years. So I think pricing is fine, but access and pricing can work in parallel so that affordability can be touched based, like SARS program or whatever, an insurance system. So I'm not asking you. This is my I'm not asking any question. I'm just sharing my thoughts, and I would like you, when you are talking with the ministerial level, something for affordability and accessibility is more important. With the recent dollar-rupee parity, a lot of challenges have been facing by the pharmaceutical company, and certain taxations is also putting pressures. So ultimate objective क्या है? Shelves के ऊपर दवाई नहीं है.
The thing which you may have seen, Shameem, by the model I presented, it was an access model, and I purposely didn't go much into access to detail because we were talking on pricing, but then the pricing is the single most important thing which determines access in this whole debate. And I'm a strong believer to learn from those countries where you have seen the improvement, because we live on this planet Earth. We are very similar with other low and middle income countries. Our problems are very similar with other countries with the similar socio-economic status. And I can give you one example. I was editing a book of mine called Pharmaceutical Policy in Countries with Developing Health Systems. There was a chapter on Pakistan, and then there was a chapter on a country called Colombia, which is, I don't know, God knows, 20,000 miles from here in South America or Latin America. When I was reading these two chapters, in pharmaceutical sector, they were so similar. The problems they have, irrational use of medicines, pricing, the similar sort of problems. So I think the similar economies with the similar socio-economic GDPs have similar sort of problems. We need to learn from those countries who have progressed further. And the progress further, as I said in my talk as well, to support pharmaceutical industry, to bring more money, to support public sector, basically. Invest more in public sector, where you provide better medicines. Many of the studies we have done around the globe, we have seen, I've not shown you. We did one study on asthma prices in 52 countries, which was published in a journal called Pharmacoeconomics, for 3 asthma inhalers, which were essential items, salbutamol and budesonide. So we looked at, and I've not shown it here, but in the public sector, for many of these countries, there were no availability or zero availability of these medicines. And these 52 countries were spread across Asia, Africa, and other parts of the world. So our problems are very similar to other countries. We need to find the solutions where the countries have made progress, which has actually gone up in the availability of essential drugs, how they have done this. And this can only be possible if you invest more resources into the health sector, especially the public health sector, to increase the availability of medicine. It's not rocket science, it's very simple. Some of the questions which are being asked to me today is about implementation. We may have these policies in place, but if they are not implemented, I can come up with the best policy, or you can bring in someone else on board to come up with the best policy. But if the policy is not implemented, there is no point. Thank you.
Assalamu alaikum. Dr. Sab, it was really wonderful presentation indeed. Thank you so much.
Sorry, I can't. Okay, yeah.
So my question, let me put my question in Urdu. چونکہ آپ پاکستان میں بھی رہے ہیں، یہاں پر آپ کو پاکستان کے جو ہیلتھ کیئر سسٹم کا پورا ادراک ہے. جو ڈرگ پرائسز کا جو برڈن ہے، سم ورڈ افورڈیبلٹی اینڈ ایکسیسیبلٹی، کیا ہم شفٹ کر سکتے ہیں تھرو کہ جو ڈائگنوسٹک لیبس کے جو ٹیسٹ رپورٹس ہم ایشو کرتے ہیں، جو ہاسپٹلس کی جو پرائسنگ ماڈل ہے، کلینک کا جو ماڈل ہے، ڈاکٹر کی جو فیس ہے، اگر ٹوٹل ٹریٹمنٹ کاسٹ کو ہم دیکھتے ہیں اینڈ ٹوورڈ دا پرائسنگ آف دا فارماسیوٹیکل ڈرگ، سم وٹ از 10 to 15% کنسیڈرنگ دا پاکستان سینیریو. کیا ہم یہ برڈن شفٹ کر سکتے ہیں تھرو آر ریگولیشنز کے جو لائف سائنسز کا جو پرائسنگ ماڈل ہے؟ اور یہ بھی ہم جاننا چاہیں گے کہ چونکہ آپ نے ورلڈ وائڈ پرائسنگ ماڈلس کے اوپر کام کیا ہے، کہ دنیا میں ہاسپٹل سیکٹرز، ڈائگنوسٹک لیبس، کلینکس اینڈ ڈاکٹرس کی فیس کا سم ورڈ کچھ برڈن شفٹ ہو سکتا ہے ٹوورڈ فارماسیوٹیکل انڈسٹری گروتھ اینڈ دا ریشنل پرائسنگ ماڈل. تھینک یو سو مچ.
تھینک یو. نہیں، بہت اچھا آپ کا سوال ہے، میں اردو میں ہی جواب دوں گا اس کا. دیکھیں، آپ چیزوں کو ان کے پرسپیکٹو میں دیکھیں، چیزوں کو مکس مت کریں. اگر مکس کریں گے ہم چیزوں کو تو ہم ان کے ایکچوئل میننگ کو لوز کر جائیں گے. میں نے پرائسنگ پالیسی کی آج بات کی ہے، اگر میں اس کے اندر ہی مکس کروں ڈائگنوسٹکس کو، ہاسپٹلس کو، تو اٹ وڈ بی ٹو کمپلیکس ٹو انڈرسٹینڈ اینڈ وی ڈڈنٹ ہیو اے سنگل پوائنٹ ٹو اسٹارٹ آور ڈسکشن اینڈ ٹاک. کیا جا سکتا ہے، بالکل کیا جا سکتا ہے، بٹ وی نیڈ ٹو ڈو ون تھنگ ایٹ اے ٹائم. We cannot talk about diagnostic with the same thing as we talk about the pricing. Pricing, because we have worldwide models available to talk about it, to improve about it. So I think we need to focus one thing at a time. In public sector, for example, in developed public sector, everything is interlinked and it's come from public money. So for example, in UK, the pharmacy services fee comes from public money, the diagnostics come from public money, hospitals come from public money, so everything is interlinked because one funder is paying for everybody. So if you have one funder paying in Pakistan as well, of course you can do that, but if you have different funders, then it would become too difficult and complicated.
ڈاکٹر صاحب، جیسے آپ نے بتایا کہ ہمارے پاس پالیسی بھی بہت اچھی ہے اور صرف امپلیمنٹیشن اس میں چاہیے. ایز اے انڈسٹریلسٹ میری نظر میں جب تک ایکویلٹی نہیں ہوگی، سب کو برابر کے رائٹس نہیں ملیں گے پوری انڈسٹری کو، تو آپ اگر امپلیمنٹ بھی کر دیں تو پھر بھی یہ جو ہمارے مسائل ہیں، جو ہمارا مسئلہ مین ہے کہ اویلیبلٹی، وہ پورا نہیں ہو سکے گا. ایگزامپل کے طور پر اگر ایک کمپنی ایک میڈیسن بنا رہی ہے اور اس کو پرائس ملی ہوئی ہے 100 روپیز MRP، اور دوسری کمپنی کو ملی ہوئی ہے 200 روپیز، سیم مالیکیول کی پرائس کی میں بات کر رہا ہوں، تو اگر آپ 10% سب کو بڑھا بھی دیتے ہیں، جو آپ نے کہا کہ ہماری پالیسی اور CPI مل جائے اور 10%، تو 100 روپیز والا تو 110 پہ آئے گا اور جو 200 والا 220 پہ چلا جائے گا. تو آئی ڈونٹ تھنک کہ 100 روپیز والا جو ہے وہ 110 پہ بھی بنا پائے گا، انلیس کہ اگر آپ اس کو ایکول رائٹ دیں کہ وہ ایٹ لیسٹ 150 تک کا سیل کر سکے. جو ہمارے ایشوز چل رہے ہیں کاسٹنگ کے حوالے سے، مٹیریل کاسٹ بڑھ گئی ہے، ہر چیز بڑھ گئی ہے، تو ہاؤ ڈو یو تھنک کہ اس پالیسی میں کس طریقے سے اس کو وقت کے طور پر اس وقت جو ہمارے مسائل ہیں اس کو کس طرح امپلیمنٹ کیا جائے اور کیسے اس کے اوپر جو ہے حل کیا جائے؟ کیونکہ اس طرح تو گیپ جیسے جیسے چلتا جا رہا ہے، اگلے 4 سال 5 سال کے بعد جو 110 والا ہے اس کا ڈفرینس اور 200 والے کا ڈفرینس اور زیادہ ہو جائے گا. تو پلیز اس کے اوپر اگر آپ ریویو دیں اپنا. تھینک یو.
دیکھیں، آپ کے سوال کے 2-3 پہلو ہیں. پہلا تو یہ ہے کہ میں نے بالکل بھی ایسا نہیں کہا کہ پرائسنگ جو پالیسی ہے وہ لوپ ہول ہے. دیر آر ایشوز ان اٹ. دس نیڈس ٹو ورک ٹو بی امپرووڈ اینڈ ورک فردر. اور دوسری بات یہ ہے کہ پالیسی جو ہے وہ ایک ڈائنمک ڈاکومنٹ ہے. ایسا نہیں ہے کہ آج آپ نے بنا دیا تو آپ اس کو بدل نہیں سکتے. یو کین کیپ چینجنگ اٹ اینڈ اٹ کین بی امپروو فردر ایوری 1 year اور ایوری 2 year. اٹ ڈپینڈز آن the consultation of stakeholders and things like that. تو پالیسی سے مراد جو ہے وہ لوگوں کو ایک you try to give support the different stakeholders and at the same time you want to promote the public health interest of the people as well. So as far as you are actually coming up with some workable solutions, that's fine. Aapne jo baat ki, you're talking in too detail and maybe there are issues there which need more work. And what are those issues? What could be solutions? I think this could be done in the framework, in a broader framework. تیسری بات یہ ہے کہ جو میں نے بار بار کی ہے اپنی پریزنٹیشن میں کہ پرائسنگ پالیسی کسی ایک پالیسی کا نام نہیں ہے. اٹس اے کمبینیشن آف پالیسیز, اور اٹ کوڈ بی مور دین دیٹ. مے بی دیر آر ایلیمنٹس ان دس پالیسی وچ WHO ہیز ناٹ سجیسٹڈ. سو مے بی پاکستان کے اپنے لوگ کچھ ایلیمنٹ اس میں سجیسٹ کر سکتے ہیں, because it's Pakistan's policy. Because what WHO gives you, it gives you a very, very generic, rough framework which you cannot take or apply. تو ایسے وہ کوئی بنی بنائی چیز آپ کو نہیں دیتے ہیں. You have to work on the model. So when you work on the models, what you are talking about, some of these things could be adjusted in that.
بہت شکریہ ڈاکٹر صاحب. مجھے پتہ ہے کہ 2 گھنٹے کھڑے ہو کے بولنا اور بڑا مشکل کام ہے. بہرحال ویری ویل پریزنٹڈ ماشاء اللہ. لیٹس گیو ہم اے بگ ہینڈ پلیز. ہمارے ڈاکٹر صاحب نے جو باتیں کی ہیں اور جو ہمارے آڈینس میں سے سوال جواب ہوئے ہیں, یہاں ماشاء اللہ سارے انڈسٹری کے پروفیشنل بیٹھے ہیں, وہ خود گیدر کر لیں کہ ہمارا ایکچولی ڈائلیما کیا ہے. جب ہمارا پرائسنگ کے بارے میں ڈائلیما کیا ہے, دس وی نیڈ ٹو فگر اٹ آؤٹ اینڈ وی ہیو ٹو کم اپ کہ بھائی ہم نے کرنا کیا ہے. یہ ڈاکٹر صاحب نے بڑا رائٹلی مینشن کہ ایک ڈاکومنٹ ہے, وہ ڈاکومنٹ کوئی صحیفہ نہیں ہے. اٹس ناٹ سم تھنگ ڈیوائن. وی نیڈ ٹو پروپوز, وی نیڈ ٹو سجیسٹ. تھینک یو لیڈیز اینڈ جینٹلمین, تھینک یو ویری مچ. ڈاکٹر صاحب تھینک یو ونس اگین. ڈاکٹر حامد از سٹنگ اوور دیئر. اور سینئر مینجمنٹ PPMA ٹیم از آلسو سٹنگ ہیئر. اینڈ فارچونیٹلی ڈاکٹر صاحب آج ہماری اکیڈمیا کے کچھ لوگ, خاص طور پہ ڈاؤ یونیورسٹی آف ہیلتھ سائنسز کے ہمارے پروفیسر صاحبان, وہ لیڈیز میں کیا کہیں گے یار, وہ ہماری جو ڈین فیکلٹی فارمیسی بھی یہاں ہیں, اور دوسرے ریلیونٹ سائنسز کی ڈاکٹر سونیا بھی یہاں ہیں. کافی لوگ ہمارے, اور جو صاحب آپ سے بہت زیادہ سوال کر رہے تھے تو وہ یہ سارے ہمارے جو ہیں ڈاؤ یونیورسٹی سے آئے ہیں. بایو ایکویلنس کے ہماری ڈاکٹر سعدیہ بھی ہیں اور ان کی ٹیم ہے. تو تھینک یو خاص طور پہ باقی سب کے علاوہ ہمارے جو ڈاؤ کے دوست آئے ہیں, بڑی مہربانی آپ لوگوں کی. آپ لوگ آئے, مجھے پتہ ہے کہ آپ کا شیڈیول جس طرح ہوتا ہے. دوستوں تھینک یو ویری مچ. لنچ از سرو. ہم چاہیں گے کہ یہ پروگرام 3-3:30 بجے ختم کر دیں. تو اگر آپ 1:30 بجے سارے واپس آ جائیں لنچ کر کے, نماز پڑھ کے, تو ہم 3:30 تک یہ پروگرام انشاءاللہ ختم کر دیں گے, آپ تاکہ آپ بارش آنے سے پہلے گھروں کو پہنچ سکیں. بہت شکریہ. لنچ از سرو.